am Dr. Nikita Pahwa. My two main purposes of making these videos is that you can do excellent in your postgraduate exams, and second, you can manage your patient well in the labor room. So friends, to begin with, I have chosen the most important topic in obstetrics, that is obstetrical hemorrhage. Now this can be broadly classified into antepartum and postpartum hemorrhage. Let's start with antepartum hemorrhage. Antepartum hemorrhage can be divided into first trimester bleeding and second and third trimester bleeding. Now the most important cause and the most important or the most common emergency in the labor room is placenta previa. So let's study what is placenta previa. Now friends, as you can see in this picture that this is a normal placenta, and this placenta which is encroaching upon the internal os is placenta previa. What are the risk factors of placenta previa? First, previous placenta previa. Second, previous Caesarean, and the risk increases with number and more with pre-labor Caesarean section. Multiple gestation more than singleton pregnancy, and there are some other causes like previous uterine scar, increasing parity, infertility, previous pregnancy termination, and many other. Now friends, the pathogenesis of placenta previa is unknown, but there are two hypotheses that the suboptimally vascularized decidua in the upper uterine cavity from previous surgery promotes unidirectional implantation of placenta in the lower uterine segment. And second, large placenta in case of multiple gestation encroaches upon the lower uterine segment. Now friends, what is the pathophysiology of bleeding in placenta previa? Because of uterine contractions, the gradual changes in cervix which leads to the shearing of placenta in the lower segment. And third, sometimes vaginal examination or coitus. Now friends, mostly this is maternal blood from the intervillous space, but fetal bleeding can occur if fetal vessels in the terminal villi get disrupted. Now, how will placenta previa present to you? Mostly it is an asymptomatic finding on mid-trimester USG, and 90% of them resolve. Why? Because the lower segment grows as the pregnancy progresses. Therefore, the lower edge of the placenta moves away from the lower segment. And second, the lower segment being less vascular allows the unidirectional growth of placenta towards the fundus, which is also called trophotropism. So friends, how will we predict the presence of placenta at delivery? First, because of lack of resolution by the third trimester, extension by more than 25 mm, posterior previa, placenta with thick edge, and placenta attached to previous scar. Now friends, the most common presentation is painless vaginal bleeding. Now this bleeding can occur in 1/3 of the patients before 30 weeks, in another 1/3 between 30 and 36 weeks, and the remaining 1/3 present with their first bleed mostly after 36 weeks. So friends, placenta previa becomes a major risk factor for preterm labor and premature rupture of membranes. The antecedent episodes which occur in the antenatal period predict the caesarean delivery at term. The other findings are vasa previa and velamentous cord insertion, and previa presents with floating presenting parts or malpresentations. Now friends, how will we diagnose placenta previa? As you can see in this picture that this is the internal os and this placenta is completely covering the internal os. This is a picture of transabdominal sonography, which is a screening method. When the distance between the placenta and the internal os is less than 20 mm in TAS, then we do TVS, which is the gold standard or the definitive method to diagnose placenta previa. But there are some special points which you need to know in case of transabdominal sonography. For example, as you can see in this picture that this is an over-distended bladder. Now this over-distended bladder will push the anterior and posterior uterine segments and it will mimic placenta previa. Similarly, you should not do transabdominal sonography when the lower uterine segment is contracting. If the fetal head is low in cervix, then you can give the patient Trendelenburg position or push the head cephalad. Posterior placenta is difficult to visualize even in TVS. See friends, as you can see in this picture, this is posterior placenta which is just touching the internal wall. It is not covering. And this is central placenta previa. What is central placenta previa? When the anterior and posterior margins of the placenta are equidistant from the internal os. Now, how will you manage placenta previa? Now, in case of asymptomatic patients, what is your main goal? We have to determine whether previa resolves with increasing gestational age. Most important, we have to rule out placenta accreta syndrome. Third, we have to reduce the risk of bleeding. And fourth, we have to determine the optimal time for planned CS if previa persists. Now friends, most important thing, how will you monitor placental location? If placental edge covers less than 2 cm in second trimester, then we will follow up at 32 weeks. At 32 weeks, if the placental edge becomes more than 2 cm, then no more examination is required for placental location. But friends, most important thing, we have to rule out vasa previa because sometimes if the placenta moves, the membranes remain. If it is less than 2 cm, then we follow up at 36 weeks. If at 36 weeks the placental edge covers the os, then obviously Caesarean section is scheduled. But if it is less than 2 cm and does not cover, then risk of trial of labor can be discussed with the patient. Now there is something called inpatient versus outpatient monitoring. Friends, inpatient monitoring can be done in case of short cervical length on TVS, rapid cervical shortening and inability to get to the hospital promptly. But the most important thing in case of asymptomatic patients is antenatal corticosteroids. Very important. And delivery for uncomplicated placenta previa should be scheduled with Caesarean section at 36 plus 0 to 37 plus 6 weeks according to ACOG guidelines. Uncomplicated previa means without fetal growth restriction and without superimposed preeclampsia. Now friends, how will you take care of acute bleeding patients? First of all, we need to admit them. Second, we need to inform the anesthesia team because decision for CS can be taken anytime. And third, there are very important points which we need to ponder upon. First, there is excessive amount of bleeding if there is flooding or blood that has spilled the ground or bed. Second, we have to determine the hemodynamic status by 3 P's, that is pulse, pallor, pressure. An obstetric shock index, which is heart rate by systolic blood pressure. If it is more than 1, then we surely need blood products. Third, the source of bleeding. Fourth, the condition of the fetus. Fifth, obstetric parameters, that is the uterine tone, cervical status. And sixth, most important, we need to book the blood products and evaluate for coagulopathy. How do we stabilize the patients? First, we need to call for help. Second, secure intravenous access with 2 wide bore needles and give RL or NS and watch for pulmonary edema, watch for urine output, oxygen saturation and most important, blood transfusion. Now friends, initially we give 2 to 4 typed and cross-matched packed RBCs without FFP or platelet if our fibrinogen is more than 250 and platelet count is more than 1 lakh. Our target HB is more than 10. Friends, if this all fails to stabilize, that is, if there is ongoing bleeding and more than 4 packed red blood cells are given, then we need to initiate the massive transfusion protocol. Massive transfusion protocol has a panel in which we constantly monitor parameters like hematocrit, platelets, DIC profile, ABG with metabolites. If massive transfusion protocol is not available, then we give type O Rh negative blood. Secondly, you need to remember that we need to maintain INR. If INR is more than 1.5, we give 2 units of FFP. If platelet count less than 1 lakh, we give 1 FRSS platelet unit, which increase the platelet by 30,000 per microliter of blood. Fibrinogen less than 200, we give 1 dose of cryoprecipitate. Now, what are the indication of delivery? Delivery, that is cesarean section, is done if patient is in active labor, fetal heart rate tracings are abnormal, severe and persistent vaginal bleeding, and practically more than 34 weeks, we need to evaluate fetal versus maternal risk factors. Antenatal corticosteroids, very important, and also Mexcel for neuroprotection for less than 32 weeks. Anesthesia, scheduled cesarean, we can give neuroaxial anesthesia, but in case of severe bleeding or emergency CS, we give general anesthesia. Now, expectant management of stable patients after bleed. When do we do expectant management? In case of self-limiting bleeding, gestational age less than 34 weeks. Why? For fetal maturity. And most important, the fetal heart rate is reassuring. This all is called as McAfee regimen. And what do we do in this regimen? We give antenatal corticosteroids, which can be given as early as 22 plus 0 to 22 plus 6 weeks and up to 34 plus 0 to 36 plus 6 weeks. Correction of anemia, anti-D immunoglobulin if required, and re-administration is not necessary if bleeding or delivery occurs within 3 weeks. Continuous fetal monitoring, very important again. Tocolysis can be given up to the time of antenatal corticosteroids. Cerclage is usually not advisable, but stable placenta previa is not a contraindication of cerclage. Progesterone has a role for myometrial quiescence, and we need to endure the patient if it is more than 3 episodes of bleeding. Now friends, in case of caesarean birth, we need to be prepared for postpartum hemorrhage. We need to book 2 to 4 units of packed RBCs, and we need to prepare both patient and ourselves for caesarean hysterectomy. Management of placenta, always avoid disrupting the placenta by your uterine incision. Now friends, most important, to manage PPH, step 1 is pharmacotherapy, that is oxytocin, tranexamic acid, carboprost and methergine. Step 2, we need to treat focal bleeding if present. As you can see in this picture, this is the placental bed. So hemostatic sutures, square sutures at placental bedside bleeding should be taken, and these sutures should penetrate the decidua and extend into the myometrium but not beyond the serosa. And this is tourniquet which compresses the uterine vessels. Step 3 is you can ligate the uterine and the utero-ovarian arteries by O'Leary stitch method. Step 4 is intrauterine balloon tamponade, as you can see in this picture, or compression sutures. Friends, this is B-Lynch compression sutures. Friends, the suture thread is inserted inside the uterine cavity from point A, then it comes out of the cavity from point B, then around the uterus for compression, and again comes out of the cavity from point C. Again it is inserted into the cavity by point D, rolls around the uterus, comes out of the cavity from point E, and again outside from point F, and point A and point F are tied together to create compression. Friends, now there is a modification of the B-Lynch suture by our own Indian gynecologist from Ahmedabad, Gujarat, that is Commock MG. This is compression plus occlusion technique. As you can see in this picture, that the first it contains two double stranded threads. One has straight needle and the other has curved needle. As you can see, the straight needle is inserted from the lateral border of the uterine incision, and it comes out posteriorly, and the straight needle is cut. Now the two free separate suture strands are tied above the uterus to create compression. The curved end of the needle is passed through the avascular broad ligament, and again the needle is cut and tied to create occlusion of the uterine artery. Now what do we do in refractory patients? Friends, we need to take the decision of hysterectomy at the right time before the patient's hemodynamic state compromises. Thank you, friends. If you have any doubt, please write in the comment section and please like and subscribe my channel. Thank you.